Good morning, everybody. Thank you for joining us for another one of Orygen's webinar series. Today we're talking about the role of antidepressants in the treatment of young people who present to us with depressive illnesses. And we're joined by Dr. Chris Davey, who will be with us for somewhere around an hour, possibly. My name's Karen Marriage, and I'm your host for the webinar today. I'm a Program Manager at Skills and Knowledge section of Orygen, the National Centre of Excellence in Youth Mental Health. Okay, so those of us who work with young people in mental health will often see people with either a primary presenting issue of a depressive illness or often a comorbid depression. It can be complex to treat and can be quite severe for some young people. And there's controversy and sometimes a bit of confusion about what the evidence tells us about how we should be selecting treatments for young people. So our presentation today will have a look at what the evidence does say and help us to think about what role medication can play and whether there actually is evidence that is effective, and have a bit of a think about what the risks might be. So that hopefully that will be quite helpful for clinicians who are thinking about how they might go about thinking about their treatment of young people who are presenting to them with depressive illnesses. So Dr. Christopher Davey is with us presenting today. He's a psychiatrist and senior research fellow at Orygen, the National Centre of Excellence in Youth Mental Health, and at the University of Melbourne. Christopher Davey is a consultant psychiatrist at Orygen, where he leads a team of psychiatrists, psychologists and other allied health professionals in the Youth Mood Clinic who assess and manage young people with severe and complex mood disorders. His research includes studying effective treatments for depression and using neuroimaging to better understand depression and its treatment. So depression is very much his area of specialty. So if there are questions that you have been thinking about and would like to have an opportunity to ask somebody who is both very clinically up to date with the treatment of depression, but also from a research perspective and what the evidence says, this might be a good opportunity to ask those questions. So Chris completed his medical degree at the University of Western Australia and trained in psychiatry in Sydney and in Melbourne. He completed a PhD at the University of Melbourne and since then has obtained a number of fellowships and project grants. So we're in good hands for the presentation today. Okay, I'll hand you over to Dr. Davey.
Great, thanks very much for the introduction and thanks for being here for the webinar. So, I really want to talk today about the complex issue of antidepressant use in young people. It is a contentious issue and has become somewhat politicised, but I really just want to today talk through the evidence that we have, look at the sort of recent studies and see if we can sort of try to place the use of medications in the broader clinical context. So I guess it won't be a surprise for any of you there just to know how prevalent mental illness is and how prevalent depression is in young people. Mental illnesses are the chronic diseases of the young, and as you can see from this chart, while physical ill health increases through the age span to really peak in older age, mental ill health peaks much earlier in young people, where it causes enormous disability and burden. Within the sort of mental illnesses that cause problems to young people, depression is by far and away the biggest contributor. As you can see from this chart from Harvey Whiteford, looking at I think World Health Organization data, depression causes really double the burden of any other mental illness. So it is the real problem, the really big problem for burden and disability in young people. So, depression's uncommon in childhood. It does occur, and when it does occur, we know that it's more likely in this age group to be the result of sort of real kind of neglect and really entrenched sort of family difficulties. But after puberty, depression, as we come come to understand it through adulthood really starts to emerge. Now, I like this chart for a few reasons. What it shows is where the onset of depression and through life where depression first strikes, and I think it is really striking just to see how the onset of depression really sort of shoots up from puberty. The other thing that this chart shows is just where that the sex difference in depression really emerges. So from puberty, before puberty, you can see that in childhood depression, males and females are roughly equally affected. But after puberty, the ratio of females to males is roughly 2 to 1, and it's sustained that way right through the lifespan, at least until older age, where it becomes the ratio becomes more equal. But depression is a real problem, one, because it's common. It first hits in those years post-puberty, but it's also highly recurrent. So while some people will only have a single episode of depression, and somewhere around half, and perhaps a little less than half, will only have a single episode of depression, many people will have a subsequent episode of depression. So roughly 60% of people who have a first episode will go on to have a second episode. Of those people who have a second episode, 70% or so will go on to have a third episode. And once you've had a third episode, the chances of having yet another episode become very high. 9 out of 10 will go on to have a fourth, fifth, sixth, seventh, etc. episode. So depression is a problem because it's commonly experienced, a first episode is commonly experienced, but recurrence is also very common, meaning it takes up a large portion of many people's lives, many of the people who experience depression's lives. And this is really just to emphasise that point. While we saw in the when we looked at the onset of depression, how that happens very often in that sort of puberty to 25, 30 years old. Because of this recurrence, the prevalence of depression, the number of people who experience depression, is fairly steady through adulthood. And you see this similar kind of pattern of females being more effective than males, roughly 2 to 1 ratio. So roughly in the last 12 months, about 8% of women will have experienced an episode of depression, and about 4 to 5% of men. The symptoms of depression, I think, are probably reasonably familiar to you. The way the DSM and the ICD considers the symptoms of depression, they say there's 9 symptoms of depression, and there's a reasonable consensus on that. I think grouping them into these 3 areas is a useful way to think of them. There are the sort of primary affective, emotional type symptoms, depressed mood, anhedonia, or the lack of pleasure and enjoyment in things, this loss of energy and motivation. There are the somatic or more bodily symptoms, the disturbance in sleep, appetite, and this motor disturbance. And kind of interestingly, all 3 of these can be disturbed in either direction. So insomnia is common, and reduced appetite is common, and psychomotor slowing is common, but the opposite can also occur. So increased sleep, increased appetite, and psychomotor agitation. And then the other group of symptoms are these cognitive symptoms. These the symptoms that relate to thinking, to the sense of low self-worth, having difficulties concentrating, and then of course the symptom we worry most about is the thoughts that young people might have about ending their lives. And the symptoms of depression that young people experience are actually very similar to the symptoms that adults experience. And this is just, in this table, I've taken some of that data from studies in adolescents and compared it to studies in adults. And there's really no significant differences. And that's been borne out by a number of studies. So depression, and it's in keeping with what we showed before, the depression, commonly has its onset in young people, recurs throughout the lifespan, and is the same illness essentially through the lifespan. So I guess one of the treatments that we use most often for depression, rightly or wrongly, are the antidepressant medications. And our use of antidepressants has increased at a slow and steady rate over the last few decades. And data shows that really in Australia over the last 10 years, the rates of use, this is a use per 1,000 people per day, has doubled and more than doubled over the last decade. And use in Australia is one of the highest in the world. So this data came out from the OECD and published recently, and it showed that Australia had the second highest rate of use amongst these OECD countries. Just a little bit less than Iceland, but more than any other country other than Iceland. I suppose one of the things to note in this chart is the US isn't represented, and it probably has more use than either Australia or Iceland, but Australia is right up there in the amount of antidepressants we use. Now when you look at the sort of antidepressant use over the lifespan, we can see that antidepressant use is predominantly amongst older people, and people in middle and older age, but it also rises quite steeply, as we saw the incidence of depression rising quite steeply from puberty. So in adolescents and young adults, rates of prescribing increase steadily through to middle age. And we have some data that rates of use are actually decreasing in younger people, which we'll get to later in the talk. So just outline briefly some of the history of antidepressant use. Antidepressants have been around since the 1950s. They were discovered somewhat serendipitously. The first antidepressant was actually developed to treat tuberculosis, and it was noted that in using this medication to treat tuberculosis, that the people who were using it seemed to have an improved mood. And the first of these was ipronizid, developed first used for tuberculosis in 1951, but shortly after started being used as an antidepressant treatment. This is the first of a class of medications known as the monoamine oxidase inhibitors. So a medication that inhibits the breakdown of the monoamines, and the monoamines are the chemicals, the neurotransmitters that seem to be have a particular role in regulating mood. The main ones being serotonin, noradrenaline, and to a lesser extent from the point of view of regulating mood, dopamine. So these are sort of neurochemicals that are released by neurons in the brain stem, and really they release throughout the brain. A very primitive system that's evident in snails and worms and lower organisms. That's been a part of life for a very long time, and seem to have a particular role in sort of regulating our mood. The other class of medications were developed also in the 50s. So imipramine was the first of the tricyclic antidepressants. It was developed as a histamine sedative type medication, also seen to have an antidepressant effect. These medications had significant side effects, and people became aware of how these medications worked, and they all seemed to work on these monoamine systems, both the tricyclics and the monoamine oxidase inhibitors. There was an effort to find more specific medications, and this led to the development of the SSRIs, the selective serotonin reuptake inhibitors, in the 1980s. They were an example of a design drug, if you like. People sort of could appreciate the mechanism they wanted to develop to block the reuptake of serotonin. They set out to develop this class of medications, and as we know, they became blockbuster medications. So for different reasons, and we can speculate that there were sort of cultural reasons, there were shifts in the way we diagnosed depression, where the diagnosis became much broader, which coincided with the release of these medications, and they became very widely used. Since then, we haven't really had a whole lot of different classes of medications. we've had one group that not only blocked the uptake of serotonin, but also of noradrenaline. We call those the SNRIs, and they were developed in the 1990s. And recently we've only had a few new types of medication released. And just briefly, I mean, we hear a lot about, become a term we use, I guess, in popular culture, that depression might be due to a chemical imbalance, and we really speculate that this might be the case by virtue of the way we could see the antidepressants worked, that the antidepressants seem to increase the availability of the monoamines, particularly serotonin, and to a lesser extent noradrenaline. Therefore we thought depression must be caused by reduced monoamine availability. But this chemical imbalance theory really isn't supported much by the evidence, and I think most psychiatrists and researchers have really dismissed that as any sort of account of why depression occurs, or in fact as to the mechanism by the antidepressants really have their effects. So the very first trial of an SSRI in young people was published in 1997. It compared fluoxetine and placebo, treated for 8 weeks, and it really showed this, quite significant effect of fluoxetine. So this was seen as very good evidence that these medications were effective in young people, and they became much more widely used following this trial, and a number of others that followed it. What really kind of disturbed this trajectory of increased antidepressant use, where we thought that these medications were not only effective but very safe, was a publication in 2004 in The Lancet. And what this publication did was performed a meta-analysis, meaning it took the results from all the published trials, but importantly also included unpublished trials to demonstrate that the antidepressants weren't really that effective in young people, and not only weren't effective but had some worrying side effects, which we'll get to. So this is from Sarah Hetrick, who's at Orygen and who leads the Cochrane collaboration in examining evidence for different treatments, and shows essentially what was reported in the Lancet paper. Now, when we look at this chart, what we want to see is these diamonds, which represent the effectiveness of the medications across all the trials for that medication. We want to see it clearly to the left of that line, meaning there was a clear difference between that medication and placebo in the placebo-controlled trials. Where these diamonds cross the line, that suggests they're not effective. They don't separate from placebo, not in any statistically meaningful way. The other thing to appreciate is where the diamond is smaller, the trials are larger, our evidence is better. Where the diamonds are wider, the trials are smaller and our evidence is less convincing. The number of people in the trials isn't large enough to give us very clear evidence. And what we can see from this chart is that, well, paroxetine doesn't separate from placebo, neither does citalopram, venlafaxine or mirtazapine separate from placebo. We can see that sertraline and escitalopram, well, maybe just to the left of the line, but not in a very convincing way. And the standout medication is fluoxetine, where there have been 3 large trials showing that it is more effective than the placebo medication. And overall, we can see that that diamond is to the left of that line. So when we combine the evidence from all these trials, it suggests perhaps the medications are effective, but not very effective. The axis on the bottom shows the number of points on a scale of the child depression rating scale, which goes up to 113 points, I think. So a difference of about 4 points on a 113-point scale isn't a very significant difference. But overall, there is a significant difference. This meta-analysis from 2007 tried to sort of quantify the difference by combining all these trials again in a larger statistical analysis. They looked at data from 13 trials of antidepressants, almost 3,000 participants. And what it showed is that the response rate to antidepressants was about 61%, meaning 61% of people showed an improvement on the antidepressants, which sounds pretty good. But 50% of people showed a response to placebo. So the placebo response was very good, and the gap between antidepressant and placebo not particularly large. So what this equated to for all of the medications was an effect size of 0.25. This is a measure of just how effective it is. And in our understanding of effect sizes, that's pretty small. And that is equivalent to a statistic that maybe makes more sense, which is the number needed to treat. So this statistic suggests, compared to placebo, we need to treat 10 people with an antidepressant for one of them to improve. So what you might appreciate is that another way of looking at it is that the other 9 people didn't need to take the antidepressant because they would have got better anyway. With fluoxetine, which we saw was the most effective, the antidepressant, the evidence for its effectiveness is a bit better. So it has an effect size of 0.46, which is getting to a more moderate kind of effect, or a number needed to treat of 6. So we need to treat 6 people on an antidepressant compared to a placebo for one of them to get better. And I should say that's not out of the ballpark for many treatments in medicine. So the placebo response rate, I guess, is one of the banes of our lives in depression, in that people seem to do pretty well with an inert medication. So it's on one hand, it's something to reckon with when you're trying to develop any treatment with depression, is that people tend to get better with placebo. On the other hand, it's kind of an interesting fact about depression that people do tend to get better when they get the sort of care and attention that they get in a trial where they're not actually receiving anything with their active ingredients. And what we can see is the placebo response rate seems to be particularly high in depression. So it's sometimes said that these medications that we use for depression are actually better for anxiety disorders. And that's true to some extent. They have a similar response rate, but the placebo response rate is much lower in OCD and other anxiety disorders. So there's a bigger gap between the response to medication and placebo. Whereas in depression, it has a similar response rate, but a higher placebo response rate. So the gap is smaller. And there's been a lot of effort trying to work out why on earth, the placebo response rate is so high in depression, and a lot of theories. And at least one of those that seems to be borne out by some of the evidence is that the placebo response rate is a function of depression severity. So where people don't have a very severe depression, their placebo response rate is much higher. Where they have a higher, more severe depression, their placebo response rate is lower, suggesting that perhaps one of the problems in these trials is that they're enrolling people with depressions that are too mild. So as if that wasn't concerning enough, that these antidepressants didn't seem especially effective, what's perhaps more worrying is that they seem to induce an increase in suicidal thoughts and behaviours. Now I should say in all of these studies where they've performed these meta-analyses looking at this phenomenon, there have been no completed suicides. So we can maybe sensibly think that if they're increasing the rates of suicidal thoughts and behaviours, they might lead to an increased rate of suicide, but we don't know that from the studies because there are actually 0 suicides from these studies. But we see fairly convincing evidence that they do, in fact, in some young people, lead to the development of suicidal thoughts and behaviours. And this chart was particularly striking. So again, if we look at the on the bottom axis, and we look at the number 1, the odds ratio of 1, anything above 1 and where that confidence interval, which is the black line there with the 2 little lines at the end, where that doesn't include 1, that suggests that there's something significantly worrying going on there. So we see for the young people who are under 18 that the rate of suicidal thoughts and behaviours when they're treated with an antidepressant compared to when they're treated with placebo is significantly increased, more than twice, more than the rate of the ratio of increased suicidal thoughts and behaviours is more than double, and our confidence interval important doesn't include 1. So that is a real worry. When we look at the 18 to 24-year-olds, we can see that, while our estimate is that it does increase suicidal thoughts and behaviours, the odds ratio does include one, suggesting it doesn't statistically significantly increase suicidal thoughts and behaviours, but it's close enough to be worrying. And then we can see as people get older, that odds ratio comes down to where in older people, antidepressants do what we would hope they do, and they seem to reduce suicidal thoughts and behaviours. But there was this sort of analysis that first came out with that Lancet paper in 2004, and people have looked at in a fairly close detail, seems to be a real phenomenon. And again, to put it in perspective, you know, this bridge study which we talked about before, this meta-analysis that looked at the effectiveness of also looked at the reported rates of suicidal behaviour. So they showed that about 3% of young people treated with an antidepressant developed suicidal thoughts and behaviours, compared to about 2% in those receiving placebo. So we're seeing a depressed young group, and of course some of them are going to develop suicidal thoughts and behaviours irrespective of whether or not they're taking the medication. And they showed a risk difference of about 1% in this trial, and a number needed to harm, which is the opposite of a number needed to treat. So the number of people that had to be treated with an antidepressant compared to a placebo for one of them to develop suicidal thoughts and behaviours was 112. So you had to treat 112 people with a medication compared to placebo for one of them to develop suicidal thoughts and behaviours, compared with a number needed to treat of 10. So, I mean, I guess that's to put it into some context. You might argue, and fairly reasonably argue, that developing suicidal thoughts and behaviours is a particularly worrying thing, and that might weight it in favour of thinking the risks are much greater than the potential benefits. But I guess that's up to each individual patient to think about and to weigh in their own minds as to whether this is something, a risk they're willing to sit with. And then just last month or the month before, we saw another article in the British Medical Journal doing a similar analysis. What they did though is they went through the study data in a fairly fine-grained way. They looked at all the records of all the reports of increased in suicidal thoughts and behaviours, as well as looking at reports of increased aggression, recoded them, and they showed, well, something similar in terms of increased suicidal thoughts and behaviours. They showed it was a real phenomenon, that about 3% of people developed on medication compared to 1% on placebo, equivalent to a number needed to harm of 52. So they, in their analysis, they said, well, 52 people had to be treated with a medication compared to placebo for one of them to develop these phenomena. And they also showed for the first time, and what perhaps has been suspected, is it can also show, they can also produce an increased rate of aggression, so that young people treated with a medication compared to placebo were more likely to become irritable and aggressive with a number needed to harm of 44. So why is it that antidepressants seem to cause this increased suicidality and aggression? Look, there's been some debate as to whether this is a real phenomenon or an artefact. I think the evidence is reasonably convincing that it seems to be a real phenomenon. And I think probably the theory that has the most support is this idea that in some young people, and a minority of young people, antidepressants can cause an increase in restlessness and agitation, sometimes referred to as akathisia, this feeling of internal kind of restlessness. And in young people already feeling depressed, when they develop these symptoms, we can imagine that these will activate suicidal thoughts and behaviours that might have been latent. And in the same way, they become more irritable, on edge, and aggressive. A related theory is that antidepressants can unmask a latent bipolarity. So we know that antidepressants can trigger manic symptoms in susceptible people, and a related theory is that perhaps people who have never shown signs of bipolar disorder up to this point maybe do become a bit agitated and develop some sub-threshold manic symptoms that cause this increase in irritability and agitation and suicidal thoughts. But it's a really important area of research, and not an easy area to research, but people are starting to turn their minds to trying to understand this phenomenon in more detail, because it's a really important one. So I can see some questions coming through, but I might wait to the end to start addressing some of those. So what all this meant was that, that people became very alarmed when they saw this data that showed not only were antidepressants not terribly effective, but also had these worrying side effects. And the FDA in the United States developed this black box warning, which meant an insert that went into the antidepressant package that warned people that they could increase rates of suicidal thoughts and behaviours. Originally just for children and adolescents, but on the basis of that data we showed you before that showed this kind of fairly linear relationship with age, they extended it for young people up to 25 years. In Australia, the TGA, which has a similar role, didn't need to take the same steps because none of the antidepressant medications have actually been approved for use in young people, which means not that that approval was refused, but the pharmaceutical companies, for whatever reason, haven't sought approval for specifically for young people. It also was reflected in sort of treatment guidelines. So the NHMRC and Beyond Blue here produced guidelines in 2011, and their guidelines suggested that prescription of the SSRI fluoxetine should be considered for acute short-term reduction of depressive symptoms in adolescents with moderate to severe major depressive disorder. And this should occur where psychological therapy has not been effective, is not available or is refused, or if symptoms are severe. And the NICE guidelines, which have only just recently been updated, say something similar. So it suggests in mild depression that we shouldn't really prescribe antidepressant drugs. But in moderate to severe depression, we shouldn't offer them except in combination with the psychological therapy, where we initially treat the illness. We might consider combined therapy, and this is a new update. In their previous version of these guidelines, they didn't suggest that, but they've updated to suggest that maybe we do consider combined treatment initially, or alternatively, start a psychological therapy where it hasn't been effective, then consider the addition of an antidepressant. And what we do know is that, with all these concerns and worries about the medications, and with the warnings that were inserted in the US by the FDA and a lot of media publicity, that the rate of antidepressant use has dropped off in young people. This paper, I think, was published in the BMJ last year and did cause some disquiet because it suggested that not only were with this reduction in antidepressant use, that there was an increase in suicidal behaviours in young people. So there were more presentations of people to emergency departments and following overdoses of medications that they were suggesting might be related to the reduction in antidepressant use. But that was a controversial finding, and a lot of people weren't convinced of the link. They didn't show a relationship, though, with any increase in suicides. So we have some worries about medications, and rightly so. They perhaps are effective overall, but not really convincingly so, and have these worrying side effects. So where does that leave us? That leaves us with psychotherapy as, I guess, the treatment of choice for young people. And psychotherapies are effective, but more recent evidence has suggested that, similarly to medications, they might maybe not as effective as we once thought. So this chart shows, they're accumulating evidence for CBT, so adding studies as they become available, starting in 1986, where we showed that CBT was really very, very effective. And study 2 showed the same thing, but as we kind of added studies, and typically what happens as we do more studies is that we tend to use the therapy in more real-world populations. So instead of sort of university students who live near the campus who have very uncomplicated, simple depressions, we extend it to sort of more real-world populations where people living in more socioeconomically deprived settings with more complex illness, with comorbidities, etc., we see the effect size becoming smaller and smaller, and that's what we've seen with cognitive behavioural therapy. We also know that many of the trials that examine the effects of therapy are not as rigorous as the sort of trials that are performed for medications. So medication trials, attract a lot of criticism because of the industry influence on them, and rightly so, but they tend to be designed with a reasonable amount of methodological rigour. CBT and other psychotherapy trials are more variable in that there are some trials that are very rigorously conducted, but there are many trials that show less rigour. So what this chart shows is how the methodological rigour of the design affects the reported effect size. So the consort adherence refers to guidelines for the reporting of trials and is a measure of how rigorous the trials are. So when there's really high consort adherence, where the trials have performed the trial in a standardised, strict way, we can see the effect size is very small. Where they're much more loosely adhered to the consort guidelines, the effect size is much higher. Similarly with the analysis of patients in the trials, where they do what's called an intention to treat analysis, which is the gold standard for analysing randomised controlled trials. It essentially means that you include everyone in the analysis, whether or not they actually turned up for therapy or dropped out during the therapy, they all get included in the analysis. The effect size is much smaller. Where you only analyse that small subset of participants who turn up to each session of therapy and get to the end, well, not surprisingly, the effect size is much higher. Similarly, with a comparison, with the type of comparison that the therapy is put up against. So with medications, it's obviously reasonably easy to find a placebo pill. With therapies, it is harder. But where you just compare people who are waiting on a wait list, waiting for their therapy to start, which is fairly commonly done in psychotherapy, the effect sizes are much larger. Where you actually compare people who are having the therapy to another active condition, where they're also sort of meeting someone face-to-face, the effect size is much smaller. And similarly, where participants in the therapy trial come from non-clinical backgrounds, typically that would be people who have completed some sort of survey and rating instrument and score over a certain cut-off and they're offered therapy, they do pretty well. When it's actually from clinics, people who have severe and complicated enough depression that they want to get treatment, the effect size are much smaller. So all this is to show that the effect sizes for therapy, while therapy is effective overall, the effect sizes are of similar kind of scope to antidepressant medications when we look at that subset of therapy trials that are rigorous in their design. And just simply to emphasise that point, a more recent study, just again comparing patients, and typically in the US especially, patients are recruited via newspaper or internet advertisement, and they do much better than patients who are coming through the clinics. So it's really now for the last part of the talk, I want to shift to looking at trials which have tried to look at this issue of how we combine psychotherapy and medication, and whether in fact with medication and psychotherapy, where neither of them are especially effective, though both overall are effective, whether the evidence suggests that combining them is a good strategy, as would seem sensible. So there are three sort of largish trials in the last decade and a half. The first of these was known as the TADS trial. It was a large trial in the US funded by the National Institute of Mental Health. And they enrolled over 400 patients between the ages of 12 and 17. And they were randomised to one of four conditions: so a combined treatment with CBT and fluoxetine, to fluoxetine alone, to CBT alone, or just pill placebo. And I've underlined the fluoxetine and pill placebo groups because they were the only groups that were in fact blinded, so they didn't know which group they were in. Whereas people in the CBT and fluoxetine and the CBT groups weren't blinded. They knew that they were in the combined treatment group or in the CBT alone group. And I think we can appreciate from the trial, the studies we showed earlier, which just showed how effective the placebo response rate, how large the placebo response rate was, that this might be significant. And this is what this trial showed. So this trial showed that the group that got the combined treatment, that got CBT and fluoxetine, did much better than the other groups. So just to orient you to what's going on in this slide, so we're looking at treatment weeks down the bottom, and we're looking at change in their depression score. So the more negative, the lower that final marker at week 12 is, the more effective the treatment was. So the CBT and fluoxetine group did much better, suggesting the combined treatment was the way to go. Whereas the CBT group, this group who had CBT alone, didn't differentiate from placebo. So those their markers are overlaid on each other, didn't separate at all. Whereas the group that got fluoxetine alone did somewhere in between. So this trial suggested that that the combined treatment was clearly better than getting CBT alone. But with that significant caveat, these groups weren't blinded. They knew what they were getting. From everything we know about the placebo response rate, people who anticipate that they're going to get better, who anticipate that they're in the gun group that got the winning treatments, that they would be geared psychologically to expect that they're going to get better, and they did. The second of these trials was conducted in the UK in their CAM services, which are probably more similar to the public mental health services here in Australia. So they enrolled over 200 patients, similar age group between 11 and 17 years, and these were randomised. So in this trial design, everyone got an SSRI, and they're randomised to either receive CBT or standard clinical care. So their question was, well, if everyone gets an SSRI, does adding psychotherapy to that make any difference? And the answer for them was no. They didn't separate at all at any point. Over the 12 weeks of treatment or up to 28 weeks follow-up, they didn't separate at all. So their study suggested, well, giving someone a medication is just as good as giving them a medication plus CBT. And the third study was another study funded by the National Institute of Health in the US. And this really looked at the role potentially of CBT as a second step treatment. So enrolled over 300 patients, 12 to 18 years. And these were patients who hadn't got better to an antidepressant. So they'd been on an antidepressant for at least 2 months. And they looked at the different options you might consider if someone had been on an antidepressant for 2 months. That was, do you switch them to a different SSRI? Do you switch them to a different SRI and add CBT? Do you switch them to a different type of medication, in this case venlafaxines, that works slightly different to the SSRIs, it's an SNRI? Or do you do that and add CBT? So I looked at this kind of crossover design, and I guess from our perspective, we were particularly interested to see whether adding CBT made any difference. And it did in this study. So you can see switch, whether you stayed with an SRI or switched to venlafaxine made no difference. But adding CBT made a significant difference. So in this study, to confuse the picture, it suggested that that adding CBT was effective, contrary to the study before. So where are we at with all these studies? So we can see that overall, we can appreciate antidepressants have only modest effects in young people, though fluoxetine appears to be the most effective of them. They have these worrying side effects, so they can increase suicidal thoughts and behaviours and increase aggression, which is of great concern to us. But CBT also only has modest effects in clinically referred patients. Much more effective in patients who are from non-referred university settings with sort of loose trial designs, but the sort of patients we see here at Orygen and many people would see in the community, it also only is modestly effective. We see some evidence that combined treatment is better than CBT alone, as in the TAD study, with this caveat that the lack of blinding likely inflated the treatment response. And this question about whether adding CBT to medication is effective, a lack of evidence from their second ADAPT study, but seemed to be helpful when there had been a lack of response to medication, as in the TORDIA study. So the question we posed at the beginning was, do antidepressants have a role in treating young people with depression? And I guess this is a summary of what I consider the evidence suggests. So psychotherapy is effective for young people and really should always be offered as a first-line treatment. There can never be any good reason for not offering it, and I guess the main reason it wouldn't be offered is where it's not available. But even then, with options to access therapies online, doesn't mean it's always taken up. Not everyone wants to engage with a therapy, but it should always be offered. Adding medication to psychotherapy appears to be more effective than CBT alone. The quality of evidence isn't that great, but there might be a role in medication as an add-on to therapy. And this might occur when the depression is particularly severe, or more often when the therapy alone doesn't seem to be leading to an improvement in the depression. So medication, I think, still does have a role in depression. We should only use it in combination with therapy. We need to monitor patients very closely because of those potentially worrying side effects that might develop. And we need more studies, and we do need better treatments, because the treatments we have for depression at present aren't really as good enough as we might hope. And that's it, so I can get to some of the questions. No, my final slide is just about the study we're doing here at Orygen, which is looking at this question of whether we should add medication to CBT. So we've got a fairly similar design to two of the arms in the TAD study, but importantly we're blinding it. So patients in our trial, they're all getting CBT, and then we're going to add, they either have a placebo or fluoxetine, and we really want to try to answer this question to our satisfaction, whether adding medication to CBT is an effective treatment strategy. And that study is well underway. So that was my final slide, and I can answer some questions now. So we have some studies, some questions that have come through. So I can go through them all. Does the use of antidepressants influence the developing brain? Well, I mean, that is a good question, and the short answer is we don't know. We do know that antidepressants have been used by a lot of young people over the last decade or two, and we can say, I think, fairly safely they don't cause any severe developmental problems. Whether they cause more subtle problems, I guess we don't know. In some ways, we would hope that they do, because one of the mechanisms we would hope treatment has is to make young people more resilient, and certainly we would hope that psychotherapy influences the developing brain, because we would hope that psychotherapy leads to people being better able to cope with their moods and emotions. And similarly, we might hope that antidepressants have a similar kind of protective role, and there is this idea that antidepressants might be neuroprotective, as in they might prevent some of the changes that can occur with depression, but we really don't know. We can speculate that antidepressants must interact with the developing brain because of this side effect profile, which seems so different in young people. This the way antidepressants increase kind of agitation, can increase this agitation and irritability in young people, but doesn't seem to be that apparent in older people. Suggests there is something about the developing brain that makes it more vulnerable to these problems. So, second question: if the young person is not getting better on antidepressants, how long should it be before we ask to switch medications? Well, that's a good question. So I think one of the things when we do use antidepressants is we want to use them in a smart way. So one of the things that we quite often see in the mood clinic here at Orygen is a young person with fairly severe, long-standing depression who has been on a low dose of a medication for 18 months. So it was started by some well-meaning person who started them on escitalopram 10 milligrams, and it's never changed despite their depression continuing in a severe and often deteriorating way. And that doesn't seem a particularly wise way to use a medication, because you're potentially subjecting them to all these side effects with none of the benefits. So when we do use antidepressants, we should use them in a way that's most likely to make them effective. So that means making sure they get a reasonable kind of dose of it for a reasonable time. So our protocol would be to start an antidepressant at the lowest effective dose. Try that for somewhere around 4 to 6 weeks. If there hasn't been a response to that dose, then usually increase it to the next step. Again, waiting sort of somewhere in that 4 to 6 weeks. And then if there hasn't been an effect, any sign of improvement on that medication, look at switching to an alternative medication. So somewhere in the order of 8 to 12 weeks after starting the medication. If we haven't seen anything, then clinically our experience is that increasing the medication to the next step to a third dose doesn't usually lead to any improvement. So it's we should change at that time. Usually our strategy would be to start with an SSRI, and we can see the fluoxetine it has most evidence for its effectiveness. So we usually start on fluoxetine and then would swap to another SSRI, so usually either escitalopram or sertraline. And where that hasn't been effective, that's when we, as a third step, we would usually look to changing to a different class of medications, and typically an SNRI such as venlafaxine. So do you think they're being overprescribed here in the US? I mean, this is the nub of the problem, really. Are we prescribing too many medications? And I guess the answer is yes and no, in that we want treatment to get to the right patients. So I think that there are many people with milder depressions who are not being offered psychotherapy or not able to access psychotherapy who would do better with psychotherapy. And I think too often young people are being treated with antidepressants as the only treatment. So I don't think there's certainly a group of young people who they're prescribed to, but people who get with moderate to severe depression often aren't accessing proper treatment. They've tried some therapy, they haven't got better, they might be continue to get worse, and those young people I think should be given the opportunity to get better with medication. So I think overall I'd say the answer is yes, so they probably are being overprescribed. And I would prefer to see that young people are having the opportunity to access psychotherapy. So the next question, why is the placebo response rate so high in depression? And well, this is a big question, because if we could understand why it was so effective, that might lead us to developing better treatments. And again, there's different theories as to why people seem to respond people with depression seem to respond particularly to placebo compared to other illnesses. And many illnesses do respond well to placebo, things like pain and irritable bowel and other medical conditions, but depression does seem to have a particularly strong response. I mean, my own theory for it is that that one of the kind of core features of depression is a sense of hopelessness and futility. And that what a placebo does in some ways is directly address that really core symptom of depression. So it directly addresses this sense of hopelessness by giving someone a sense of hope, because they do hope they're going to get better. They're enrolled in a trial where they're getting a lot of attention and people are looking out for them and engaging with them and seeing them regularly, and it does engender a sense of hope. So that would be my theory as to why depression is particularly responsive to placebo, but in truth we don't really know. And the other part about placebo is that there are two components to the placebo response. So one is this expectancy, this idea that that you are going to get better. The other part of it is just what in a statistical sense is called regression to the mean, but we could otherwise think of just as the natural tendency of depression. Like depression tends to get better, not for everyone, and for some people it can be intractable and chronic, but for many people who have an episode of depression, it tends to get better. So there's this natural kind of natural improvement or regression to the mean that occurs, which is the other component of the placebo response. And depression is an episodic illness. People tend to have an episode that gets better that can also make it particularly susceptible. Do longer-term psychotherapies that go into deep issues have any research evidence? CBT is short-term and symptom-focused. So, I mean, CBT and the other therapy that has most evidence for it in depression is interpersonal therapy. But both of those therapies seem to do particularly well in depression. And I don't know that it's necessarily because they're particularly more effective than longer-term psychodynamic therapies. It's just that they make themselves more amenable to treatment, to studies. So the problem with longer-term psychotherapies is getting the evidence that they're effective. Because when you think about a trial design, you know, they're expensive to run. You need to try to standardise the treatment to some degree. As we saw before, you know, the comparison treatment is really important for psychotherapy trials. So to really see whether a psychotherapy is working, you need to control for the amount of attention people are getting, the amount of face-to-face contact they're getting. That just makes it terribly difficult to look at comparing a 5-year psychoanalysis to a control treatment. I mean, who on earth is going to agree to be randomised to one of those conditions where you might sort of get the prize and get 5 years of psychoanalysis, or you might, you know, luck out and just get nothing for 5 years. So it's very impractical trials to run. So I think that the evidence that favours IPT and CBT is largely due to them making themselves more amenable to research studies rather than necessarily being more effective than, you know, sort of longer term, deeper therapies. And they do have some evidence. I mean, people are starting more. I think there's been some reluctance in people from a more psychodynamic tradition to involve themselves in research trials, but there is some evidence that they're effective, and I think they're likely to be just as, if not more so, effective than the shorter-term therapies. Next, it sounds like we really need to have a good formulation of the patient. All the factors likely affecting depression may help with medical decisions. I mean, I can only agree with that. I mean, I'm a very big proponent of psychotherapy as being the first-line treatment and the treatment that everyone with depression should get. And, you know, a cornerstone of good psychotherapy is doing a good formulation and trying to address those factors in the psychotherapy. But, you know, where psychotherapy doesn't seem to be leading to any improvement, you know, despite our formulation, I don't think it discounts the fact that medication might still have a role. I wonder if you can comment on or explain the unpleasant emotional numbing that some young people report on SSRIs. I mean, that is an aspect of using antidepressants. It isn't really that well recorded in the literature, despite it being a phenomenon, and I've heard it enough from enough young people. I mean, and I wouldn't say even the majority of young people, but say 5 to 10% of young people will describe something like emotional numbing, and I'm not really sure what the answer to that is, but it is one of the speculated ways that antidepressants seem to work is that they seem to reduce the tendency to experience negative emotions rather than make people experience more positive emotions, which is a good thing, I think, to have less negative emotions is part of getting better from depression. So perhaps that emotional numbing is more the experience of having less negative emotions and not responding in the way you usually would, and that feels like something like numbing. But I think we're going to speculate on that. Due to the high rate of suicidal ideation, how frequently should young people be seen when on antidepressants? Another good question. So, I mean, for one, it's not really high rate of suicidal ideation, so I'd emphasise that these aren't common problems, but common enough. You know, if we see 3 to 4% of people developing suicidal thoughts and behaviours when they're starting with antidepressants, that's worrying enough. So I guess the guidelines would say that young people should be seen each week for the first 4 weeks, and then, you know, regularly after that. And I guess after that, typically, it would obviously depend entirely on how the young person's going. If they're developing suicidal thoughts and behaviours, you continue weekly. But if they haven't developed any suicidal thoughts and behaviours over those first 4 weeks, typically we would see them somewhere between every 2 to 6 weeks, depending on how they're going. Typically every 4 weeks for the first few months, and then maybe a little bit less frequently. But I think that's a really important question, and especially that first 3 months, they should be seen frequently. And lastly, what are your thoughts about indications that high dose and long-term use of antidepressants can lead to apoptosis? So I'm not really familiar with that. So apoptosis it means cellular death, and I'm not familiar with that theory at all. So I'll look it up and see if I can come up with a more sensible response. But I think that's all for now. So thanks very much for joining us for the webinar, and I hope you have found it interesting.
Oh, thank you. Very interesting. I think many of us do a lot of treating of young people who are presenting to us with depression without having a very thorough idea of what the evidence says. So I think you'll probably agree that we now feel more informed than we would have done, and that may hopefully help us to both make some decisions, but also to articulate why we're making the decisions that we're making, and to let young people and their families know what the evidence actually tells us when we're making the choices to use one treatment over another, or to combine them, or to make decisions to change tack when things aren't going well. So I hope you found that as informative as I have, and that it helps you both to make some decisions, but to articulate why we're making the choices that we're making and the treatment decisions that we do. Okay, so I'll just reiterate that if you're wanting to go back to see the webinar again, or if you have colleagues that weren't able to log in today, come back in a little while to the Orygen website and have a look at our past webinars. You'll find both this one that we have completed today, but also a number of other webinars that might be relevant to your practice with young people with mental ill health. And we have another one coming up on the 17th of March. So if you're interested in the idea of how we work with young people who have anger issues, another very common issue in clinical practice, you might be interested in this webinar presented by Dr. Alex Parker on the 17th of March at 10 AM Australian Eastern Standard Time, that is. So do come back if you're able. We also know that many clinicians working in this area are languishing a little behind the changes that are occurring in the delivery of treatments in an online world, and that our young clients are often a little bit ahead of where we're up to in their use of technologies. And Australia is really leading the way in developing and understanding how technology might be used to assist us in delivering treatments to young people. Orygen have partnered with the Young and Well Cooperative Research Centre to develop a certificate in young people's mental health and technology. So if that's an area of your practice that you would like to be a little more up to date with, you might want to come and check out the certificates that are available in young people's mental health and technology, also on the Orygen website. Okay, so I'd like to thank Christopher Davey for his time today, and thank you for your participation, and we hope we see you again for another webinar with us.
Thank you.